away you go.
Do you think that let's see if I can share screen? Yes, I can. Okay. Thank you, Kipros. It was a lifetime of data and research and beautiful slides as usual. And my God, takes my breath away. And okay, so my name is Susana. I am an obstetrician and fetal medicine doctor. I trained with Professor Nicolaides. And I am at the moment working at the Royal London, and I spent the last 7 years at Kingston in South London. So I'm now in East London, but I have been doing the twins clinic and managing and helping twins mums for a long time now. And I was asked to come and participate in this webinar to talk about physiological birth and family-centered cesarean sections. So I must say that this is the first time that someone asks me to talk about this. So it was quite interesting, and I hope that I can share a little bit of a mix of what is my experience to what is in the literature, and together with what I've heard from health professionals and from women. So what is this? What is a physiological birth? So there's a few definitions out there, but it's basically a birth where the baby is born vaginally following spontaneous labor that has not been modified by any medical interventions. And in some definitions, they are more specific. What is medical interventions? No induction, no augmentation with oxytocin, no instrumental delivery, no cesarean section, no epidurals, nothing. Just be the lucky one that comes and pops the baby out. So, and I'm sorry to disappoint you, but physiological birth, it is not an option. What do I mean? We can't choose it, yeah? So sometimes is a no option. And that is when people have no option for intervention, or when they live in places where there's no antenatal care or very poor intervention rates. And that is proof that the mortality rate for mums and babies is very high. Nature, unfortunately, is not very kind sometimes. And that's exactly why there's midwives and obstetricians. Now, can we make physiological birth, can we make it an objective? Can we make it an aim? Can we discuss with the woman and see what are the expectations and try to aim for a safe birth that, if it's possible, with little intervention? Yes, so if we want a safe birth, we can aim for a little intervention as possible, or only to intervene when it's needed, avoiding doing too much too soon, but also not allowing things to be too late for intervention or too little, where the outcomes then are less good. And this is for singletons. If we now apply this to twins, where, I mean, Professor Nicolaides was very clear to say that the complications are a lot higher if we compare twins with singletons, from the extremes in terms of stillbirth, in terms of neonatal death, and even and this is from the Embrace, so this is UK data, even in the UK, where the outcomes are so much better. If you look here on the right side, in about half of the cases, they concluded that we could have done better. So probably we have done either too much too early or too little too late. Now, this is not only true for babies, is also true for mums, because as we have been discussing throughout, the complications for mums and the risks of needing a cesarean section are much higher in twins. Now, how do we solve this problem? So I think that the first thing is, especially when we are discussing and deciding mode of delivery, is to put on the table what is the knowledge, what are the personal circumstances, but having both the family and the medical team the aim for a good fetal or neonatal and maternal outcome. And then it's taking in account from the family perspective, what are the expectations, what are the wishes, what are the fears, what is the cultural background, what are the previous experience as a mum, and together with what is happening with that pregnancy and with all the research that has been going on for decades now, and that Professor Nicolaides has been leading since the beginning of fetal medicine. So what is then these conversations and this physiological birth? I think a lot is about bringing expectations together, and it's about good communication. So in twins, a lot comes through the scan machine and the hands of a good obstetrician and sonographer. It's explaining the ultrasound's findings, is what are the positions of the babies, how is the baby, or how are the babies growing, what are any complications present, and then making a recommendation. Because there are very clear recommendations, but the variety of combinations is so big that needs the experience and the expertise to then put together with the patient's expectations. And of course, not every patient accepts what we recommend, so it's exploring alternative options and discussing risks and benefits, and exploring why would a clever woman declined what the evidence is suggestion, exploring fears and anxieties. It's a little bit anticipating also the future, introducing the wider team, the neonatologists, the anesthetists, and involving the family. And for me, very much establishing a relationship of trust. Now, there are some, when we come to mode of delivery, there are some very clear indications to say that it's safer to do a cesarean section in twins, from monoamniotic to the triplets, to when the first twin is not cephalic, or when the mum decides that for her, that's her choice. Even when we decide for an elective cesarean section, there are a few women that will come in labor beforehand that will end up having a vaginal birth. And also for the ones that, because there was an uncomplicated pregnancy, because the first baby was cephalic, most of them, I mean, possible in primips and multips, but likelihood of a successful vaginal birth even higher in multips. Still, about 30%, despite starting with the aim of a safe vaginal birth, they will need to be kind of a guided or recommended intrapartum cesarean section. And in about 5 to 10% of the cases, the first baby is delivered vaginally, but we need to do a cesarean section for the second one. Now, there are the extremes, and again, how the babies are growing, what is if there was any complications during pregnancy, if labor didn't surprise and was preterm. So only a few will come to this debate of what is the best option. And it's a little bit matching what the book says, what the evidence says, then what the variety of women and expectations and experience wants to do. Because I can tell you that, you know, I have induced a woman that was a multip with twins, both twins breech, and she wouldn't accept a cesarean section. So again, the recommendation is to do a cesarean section, but for that woman, because the babies were well grown, because she was a multip, after discussing risks and benefits, she ended up having 2 breech deliveries and 2 healthy babies with a safe delivery. The same way that many women with cephalic babies, where we say that the chances of a safe vaginal birth is actually very high, they opt to have a cesarean section, and we support them in that decision. So it's not only about what we write in the books, and it's the real science, and improving the outcomes is matching what the book says with what are the expectations, and the communication here is key. Now, for those that go into a vaginal birth, again, how can we minimize intervention, still keeping the labor safe? So there's the fetal monitoring has a very important role. And one of the things that we are monitoring two babies at the same time. So always we say to pay very attention that we have always two different recordings, because it's very easy, given the technology, to be monitoring the same fetus twice and then leaving one unmonitored. And we have proposed a couple of checklists, especially to improve the communication, and to be aware that if you have a twins mom coming into the labor ward, she is a high-risk patient. She will need more staffing. She will need more likely to need theaters. The risk of bleeding is higher. The risk of needing intervention is higher. And of course, in labor is a very dynamic process. As I told you, in 5 to 10%, even despite the first baby is born cephalic or vaginally, the second one may need still a cesarean section. So it's about taking into account what is happening. Of course, again, to assess how is the fetus, how are the babies in labor. It's now a little bit less the ultrasound, although we also use ultrasound in labor, especially to assess the position of the twins, but is more the CTG or the fetal monitoring, and how to use that tool, not to do too many unnecessary interventions, but at the same time be able to recognize when one or both need help. And this, of course, always taking into account the wider team on the labor ward, and including the family and the woman on these discussions. Now, what if a cesarean section is then needed or is requested? How can we make a surgery safe for the delivery of two babies, together with a positive experience for the family? Especially, I would say, when this is against their expectations, where their dream birth was a vaginal birth, but, you know, for the safety of the babies or the mums, a cesarean section is needed. So here it comes, this family-centered, also called women-centered, family-friendly, gentle cesarean section, natural cesarean sections. There's a world of terminologies out there. And I think the first publication was actually called women-centered. And from then there's been several other names suggested. So some of the UK hospitals actually have already, like the Royal Surrey, a wide of information, including leaflets to family-centered cesarean section information leaflet, as you see here. And what is it? A family-centered approach is very much a combination of things that aims to improve the experience of the family and the participation of the family in that moment that is highly medicalized and tends to be led by the medical team. Is how can we put the patient at the center and feeling this at the center of what we are doing, when what we are doing is highly technical and highly medicalized. It's a little bit, you know, sometimes in obstetrics, there's a lot that we compare with trauma. And for the cesarean sections are very, very common procedures. And sometimes always the way the hospitals are looking at improving timings, improving efficiency, sometimes almost looks like a production line. And because of the way we work and the highly specialized that doctors became, the doctor that does the scan is not necessarily the doctor that makes the decision. It's not necessarily the doctor that does the laser. It's not necessarily the doctor that does the cesarean section. So there's like a production line, and there's a risk of taking the humanity and the continuity in this process. This is just an example of a trauma theater, and for us this is, I mean, looks awful. It's not our normal setting, but for the patients that, for many, a cesarean section is their first time in an operating theater, they may feel exactly the same. So what is this family-friendly cesarean section? So it's about antenatally, it's about having time to explain the process, to explain what happens during, what happens afterwards, is reducing the unknown, maybe introducing to the neonatal unit if the babies are expected to go to the neonatal unit, is to know the theater environment in advance, is to have this conversation about expectations and keeping a little bit the open-minded, that there's a constant reassessment of risks, and change can change, and things can change at a short notice. Now, on the day, how can the team make this a positive experience? Is very much about including the family as part of the team, is introducing themselves, is facilitating the small things that may be very important for the couple. It could be from listening to the Quran to listening to classic music, or having a bit more dim lights, or allowing the early skin to skin, and having an anesthetist that is going to put the equipment, the ECG equipment, a little bit out of the chest and more into the shoulders, so it keeps the chest clear. It's avoiding lots of equipment and cannulas in the hands, so the mum can have a skin-to-skin contact very early. It's about having clear drapes or lowering the drapes to allow the family to see the birth and the baby coming out of the womb, and is delaying cord clamping as the same way we recommend in a vaginal birth. For the women, what has been described is a feeling that she's in control, a more positive experience, and the possibility of take photos, listen to their own music, a little bit feeling included. Now, when we look, what is the evidence for this? Well, there's very little written about the evidence, and there's one recent paper. I mean, very small numbers. I doubt a little bit. I mean, it's about 60 cesarean section in each arm in a 2-year period, which sounds very little for a long time. But finally, this study did not find any statistical difference in maternal or newborn outcomes, including maternal satisfaction, with the routine standard cesarean section and the family-centered cesarean section, which in this case, they called it basically the one that, the drapes are lowered and the skin-to-skin contact is facilitated very early. There was earlier skin-to-skin contact, but no significant differences in the women's experience. So what is this family-centered cesarean section? From the doctor's perspective, it's a cesarean section. I am as gentle with the tissues and with the procedure if the mum wants to see the baby or doesn't. if the drapes are down or not. So from the technical point of view, is the same. Is the same surgery, maybe a better experience. And these images are actually from the first BJOG paper from 2008, where the women-centered cesarean section was first described. Now, I wonder why the paper didn't find any difference. And because I don't know what is your view here, but you know, women usually report a positive compliment when these small things are discussed with them. But I wonder if it goes back to the communication. It's not so much about if the drape is up or down, or if the baby is in the first minute in the chest, or if it's 5 minutes later. It's more about including, feeling part, not feeling part of a production line, is having a procedure that is humanized, is for the doctors to understand that, yes, we do it day in, day out, but for that couple, for that family, is a very unique moment, and we should participate, engage, and be emotionally connected somehow, the same way that we are technically competent. So this was very quickly what I had to say about the family-centered cesarean sections and the physiological birth, specifically for twins, where, yes, we can aim for that. And I think that the communication and the discussions are key for good outcomes and very good experience from the patients and from the professional and the team.